location in which primary care physicians could be authorized to give orders to paramedics. We also worked with TransCare, another ambulance agency in the community that unfortunately is no longer with us. And we were able to be very successful in, during our first 5 months of this program. We had 36 encounters and only 5 patients needed to be transported to the hospital. And this was among a homebound, frail population, and in coordination with our Hospital at Home program, one of many population health initiatives. We think this program was extraordinary success and is ripe to be expanded and scaled across our entire population that we manage. However, unfortunately, when TransCare was no longer able to provide, due to bankruptcy, we were no longer able to provide the service, and it's been now almost 4 months, I think, and we still have not been able to relaunch the service. We do think that we can work not only with other private non-911 services, but we also think that we no longer want to be vulnerable to that type of any kind of instability, and Mount Sinai should be able to provide that service to the populations it serves across the city. With that, I will turn it over to Dr. Warshaw.
Good evening, Chairman Schoen, committee members, and members of the audience. My name is Abe Warshaw. I'm the Senior Vice President and Chief Medical Director of Access Services for Mount Sinai. I'm an emergency medicine physician for 25 years, or a bit more. I'm board certified. In the past, I've been very active in EMS. I was the medical director for 911 services at North General, and anyone who came to North General as a medic or an EMT would know how much we appreciated EMS when they came. I'm here to talk about one aspect of non-911 transport needs, which is the transfer service of the Mount Sinai system. Basically, transfer service is in place at Sinai to affect transfers, both external transfer from outside sources into the system, and also move patients appropriately within the system to get the services that they need. And as you can see from these graphs, what you see here is the first one on the left shows 2013 on to 2014 and 2015, and you see by quarter, you see a steady growth in the need. And you especially see a spike after the end of 2013 when the merger occurred with Mount Sinai and Continuum. And what you're seeing here, for a great part, is the beginning, and just really the tip of the iceberg, of the population health efforts of the system to get the patients to the right place and the right time. So external transfers might include patients coming from the community, from the outside, near and far, who need continuity of care at Mount Sinai, or need a special care not available within their community, and we are bringing them in to get the care that they need. Internal transfers is really making sure both patients being transferred from one facility within the system to the other, sometimes round trips, sometimes from outpatient facilities into the system, getting again the care that they need, going to the right place. They can give a high quality care that's used to giving the volume of care that makes for good quality and gives the patients really the experts that they might need within the system. What we have found, and we've really had great relationships working with the private non-911 companies, and we use a number of companies, we work with them closely, and they do a great job for us. But what we have found is, as much as we work with them and the resources that they have, it's not enough. We still have times where patients are waiting, where STEMI patients and stroke patients are waiting longer than we'd like them to wait, just like the person who wants an ambulance when they're having their stroke or their MI, they want an ambulance in there right away. It's just too much need right now to meet those needs and also meet these internal transfers and external transfers. So we really feel, in order to meet those needs, the NICU cases that need to be taken care of by a team, we feel that although we enjoy working with our partners and they can meet some of our needs, in order to to fully meet the needs of the system and get the community what they need and get the people to the right place at the right time, we really need our own resources as well. Not only due to volume, but when we have special needs, to be able to get those in place right away, and should the abilities of any of our partners change or their status change, that we're still ready to serve our population. Again, getting them to the right place at the right time and getting the care they need. Thank you.
So I'm going to bring us back to the crux of the matter. Did you move forward? Yeah. And that's really public need and addressing public need. So before you see the definition from Article 30, the demonstrated absence, reduced availability, or an inadequate level of care in the ambulance or emergency medical service available to a geographic area which is not readily correctable through the reallocation or improvement of existing resources. And these variables also are included for you that help define and identify types of need. So, as you heard from my colleagues, we've begun to outline where there's expansion and where there's services that are being stretched. So the 911 system response time metrics that we commonly see, I believe, are a marker for the ability of the current New York City ambulance resources to meet community need. Patient transportation by ambulance is provided by many of the same resources that also provide 911 service. The healthcare community relies on these same ambulance providers to provide the additional services that you heard about. Inter-hospital transfers, hospital discharge transports, interfacility transports, and also some of the novel and new care that we think EMS will provide to our community. All patient transportation functions are vital to efficient healthcare operations for our city. So as you previously heard, bankruptcy of one of the private ambulance companies destabilized the healthcare sector, requiring New York State Department of Health to approve emergency expansion of several EMS providers. 81 ambulance cross relocations required coverage just in the 911 system. 7 ambulance or 12-hour cross relocations required coverage from Mount Sinai Hospital and Mount Sinai Beth Israel. Mount Sinai West was granted an emergency expansion to immediately cover 4 additional cross relocations. A need for a more stable safety net to maintain the provision of EMS care, mitigating for the potential loss of any service provided in New York City for any reason is essential. So what here you see are just the average response times for the calls for 2015 for New York City, reported by the Fire Department of the City of New York. On the following slide, and I want to point out this all happened prior. Uh-oh, that's not good. Can someone just produce that and just hit the red button? Hit the red button for you non-Mac users. Yeah, you can cancel or okay. Thank you very much. Sorry for that technical issue. So the point I was trying to make was that prior to the loss of TransCare and its bankruptcy, you see the response times in New York City for all sectors from 2010 to 2015. And unfortunately, we see these response times increasing in every borough except maybe Staten Island. If you look at the most I'm sorry, can you advance the slide? I mean, it's not, seems to be.
We're not vacuums.
Okay, so for segment one, the most critically ill patients that we respond to in New York City, in all 5 boroughs, we see over the last, from 2010 to 2015, an increase in response time. So despite the increases in resources that are asked for or provided to the system, we are not seeing a positive impact. I'm good, I got it, thank you. So additional evidence of public need. So of our assessment, of just looking at the 73 EMS providers that you go to the REMSCO website that are located in New York City, and this is a rough estimate, but 26 of them are voluntary non-for-profit agencies. So these are very small volunteer EMS services that provide service to a community. They have no mission or ambition or finances to expand. So they are not able to help with the additional needs that New York City requires, nor are they capable of providing the advanced level of services and coordination that we, as a New York City health system, will require as not just Mount Sinai, but other health systems begin to do population health management and move patients throughout the city. The 4 municipal agencies that exist, fire and police and other agencies, do not share that mission beyond 911 of moving patients and transporting them between hospitals and between during non-emergency areas. You have 18 proprietary agencies which have a specialty focus. They are not, again, providing general care, general response to the community. You have 14 hospital-based services that probably will intend to expand as well, but to meet their all individual needs, but not sufficient to serve all of the purposes that we as a community, a healthcare community, will require. And then there are the 11 commercial agencies that do make the case that they can expand. But what I'd like to share with you is Mount Sinai performed an RFP and requested of these agencies that they provide, if they were capable to expand to meet our needs, to provide the services that Mount Sinai requires. 4 ambulance agencies responded. We've contracted with 2 of them to provide some of the services that we require and New York City requires. None were able to manage all of the additional services that our community requires and that we requested. So I'd like to summarize for you. So what I've demonstrated and shown is there's an increase in response time despite fire department growth over the last 4 to 5 years. We have an increasing and aging New York City population, an increasing healthcare population management outside of the hospital, which is going to require new and expanded EMS services. We have increasing regionalization of care, requiring interfacility transports, and which will require increased interfacility transports. We requested of the current agencies that provide ambulance care an RFP to provide additional services, and we realized that there was a need for Mount Sinai to shoulder some of the burden to provide these additional ambulance services in the 911 service area, in interfacility transfer, in hospital discharge operations, and the new and expanded models that we demonstrated today. Additionally, the New York City community requires the development of a diversified ambulance provider strategy to maintain a safety net for New York City to mitigate for the potential loss of any EMS provider for any reason. So, that concludes my part. I'm going to bring up Dr. Ramsey, and I think he's going to entertain some of your questions.
Thanks for your allowance of us to present this. The questions we will entertain, starting right now.
Okay. I'm not sure how entertaining my questions are going to be, but we've got an audience, and please hold your applause. I'm sure there won't be any. Well, thank you everyone for coming this evening, and I'm interested, I'm intrigued. I have a number of questions that I've written down, and if my committee members here will allow me the opportunity to ask them and perhaps show my, I'll say, inquisitiveness and ignorance perhaps at sometimes, and please enlighten me. And I think it's helpful to everyone that we be as specific and we're clear about what is happening, since we are at a time of dynamic change in EMS. And we may not all understand what it is, and I'm not sure exactly what you all are hoping to do in some respects. Starting off, I think one of the things that we need to establish is, and we're going to have Ms. Tadeo, you will speak, I assume, later, and I don't mean to speak on your behalf, but one of my questions is, okay, so the expansion would go from a circumspect area of Manhattan to all 5 boroughs. But you want 11 ambulances. Okay. One, where did 11 come from? And you're spreading those 11 ambulances over the 5 boroughs. It seems a dilution of those 11 ambulances. And that's where it comes.
Okay, so what you'll find is I will go to different
Dr.
speakers.
Ramsey, perfectly
to
fine.
So I think what you've heard is, an initiation of our entree into the 5 boroughs, being able to do some interfacility work to support our current system needs. We anticipate in years to come we will be able to also add additional ambulances. So we are not deploying ambulances to all 5 boroughs to sit in those 5 boroughs to do 911 response. We are going to maintain our current footprint of 911 response. Those additional ambulances are to provide interfacility work or inter-system work that will connect these new these new population health management strategies, these increased transfer requirements, these new models of EMS care. So this is the beginning, and our commitment will continue.
And if I can add to this, so don't picture 11 ambulances out there, okay? We do have a fleet, some of them aging, so we need backup in terms of maintenance. So we're not planning on 11 additional ambulances, as Kevin said, around the 5 boroughs. Some portion of that will always be used in a backup mode, out of service backup mode.
Okay, but
Does that answer your question?
it does, but not completely, because
Okay.
my concern is, if you're looking for the certificate of need to be the 5 boroughs, you're getting coverage as you choose, but you might have a couple on reserve, and so maybe you're down to 7 or 8 ambulances, or not, whatever the number is.
Okay.
And why does a territory need to be expanded? And if it does need to, I'll leave that. Tell us again, why the territory needs to be expanded?
Well, I'll actually go to Neum, again, talking about, and you can see this map of all the boroughs and our encounters in all those boroughs in terms of our patients.
Yeah, I can start to answer, and I think that Dr. Warshaw will have something to add. The reason for the expansion of the territory is, especially for things like transfer service, the community locations and some of the additional services that we provide that are non-911 response related services, the community that we've been mandated to serve through Medicaid reform and through Medicare reform extends across the 5 boroughs wherever we have community physician practices. And so there are populations that are spread across the 5 boroughs for whom we need to provide coordination and transport services. And I think Dr. Warshaw might be able to add something on some of the facilities that we work with in the boroughs.
Well, I think the use for transfer service, it would be an iterative process. It might change depending on what our needs. So we're finding, hey, we're working with our partners and we're getting ETAs for an arrival of 20 or 30 minutes, and which we need for some really sick patients to get those patients picked up and go where they need to be. And we're finding the arrivals are really 50 minutes or more. So we say, well, what are our needs? How can we consolidate some of our new resources into helping reduce that? Or how can we do some of the work more, closer, so that the vendors, our partners, can do something, in another area. But we do have, between Staten Island, Brooklyn, those areas, we do have a big need to have timely response, and a lot of times we're not seeing it. So I think that we would look at programs and figure out ways to get those patients taken care of in a timely way and get them where they need to be. So that's what I don't think we're just going to have them sitting there, but I think we would have a real strategy in conjunction with the other resources available outside the system to get the patients in the areas outside of Manhattan where they need to be.
Yeah, starting with my opening comments, and I can even go further, there is no plan at all for us to take over any of the arms of patient transports and do that all by ourselves. From my opening comments, this is about the fact that we see patient transports really going much higher, really for the foreseeable future. We can't do that by ourselves. No entity can do that by ourselves. The 911 system is stressed right now. It will continue to be stressed. And any shift of higher volume in any of the other arms of transports is going to put pressure on one of the other arms. So this is about all, and I mentioned that before, all the entities. I think there's opportunities to be collaborating with us, to really all have opportunities to increase their business. This isn't about, truly, this is not about us expanding into the EMS world and all of a sudden having all of us, all our EMS CSLs be ours. This isn't about taking over the full transport service. This isn't about doing all the discharges from hospitals. This isn't about doing all the transfers from dialysis centers back to home. This is about this new world that's here now. So this isn't really future, it's actually now. And for us, we were already looking at this, but the TransCare piece showed that not just us we were vulnerable, but really our city was vulnerable, and it still is. And for us to not be able to work and have our patients at one site, we're developing centers of excellence. All hospitals will be developing centers of excellence. We have to be able, so right now, for instance, if we have a patient down at Beth Israel that needs to be transported because they're on the transplant list, we have to, and they're acutely ill, we have to use Abe's services with another outside vendor, right, to be able to get them up there. We will still need that in the future, but we want to have the flexibility to be able to do that now. We have patients in Brooklyn, at Mount Sinai, Brooklyn, who right now, when they have a head bleed, we are completely dependent because they don't have neurosurgical capabilities there. We truly have to get them into some hospital quickly, and we are completely dependent on that day's busyness of an outside vendor and whether they can help us in a timely fashion. We have contracts and affiliations with Bronx Lebanon, so literally every borough we have significantly strong affiliations with hospitals that count on us, and we need to be able to, for patients, this isn't about for Mount Sinai, this is for patients. They need to be able to be given the highest quality, timely care.
Okay, if I could follow up Dr. Ramsey and Dr. Jason. I understand you just finish up, you kind of just concluded with patient care, but it seemed like it's all intra-Mount Sinai, and this seems that it's an application that is designed for the benefit of Mount Sinai, and you throw in the patients at the end. Good. My question is, someone looks at this and says, why is this not a very self-serving request to give carte blanche to Mount Sinai West to let you do whatever you need to do so that your service model, your healthcare model is facilitated to its max?
Great question. Okay. So again, we'll start with Neam again, Kevin, and we'll run through this. Okay? Because remember, whatever we do to expand our needs is going to put stress on everybody.
So I think probably a clear example would be as a larger system now, and we have facilities in 3 of the 5 boroughs in our own facilities. So moving a patient, if I take the Mount Sinai Brooklyn example, a patient who has a head bleed there and can't get the care that they need there, moving that patient from Mount Sinai Brooklyn to Mount Sinai Hospital on the Upper East Side, which we're reliant on other contracted entities to do, is something that brings actually zero economic value to our system. It's just getting them from one of our hospitals where a service cannot be provided to one of our hospitals where that service can be provided, so that they can receive that care, or to somebody else's hospital if we can get them there closer, quicker, where that can be provided. So as we have locations, and we have the same situations with some of our urgent care center partnerships or our community locations, physician locations, we have locations across all 5 boroughs where when a patient shows up there, we're expected to be able to get them to some place where they can receive the care that they need, whether it's one of our facilities or somebody else's. But we do have our locations spread out, again, I said hospitals in 3 boroughs, but other locations across all 5 boroughs and beyond, where currently we're dependent on other outside contract providers for if a patient needs to get somewhere in 20 minutes and it takes an hour, we're kind of stuck. And that's to meet that patient's need. So really part of the legacy location of Mount Sinai West's geography in a core part of Manhattan was not contemplating as much getting patients to the old model of, it was more about the old model of kind of more emergent transport from home to hospital, as opposed to the newer model of there are greater scientific advances at certain facilities, again ours and other health systems in the region, and we want to make sure we can get the patient to the place where they can get the most effective care, regardless of whether that's in the small geographic box around one of our facilities or not. Anything?
Doctor, don't go too far yet, if I can. I'm going to jump into the question
Yeah,
if I can. So let's say you've got some poor person who's come to your facility. You realize that the person is better served by putting them into another part of your network of healthcare, and that's going to require an ambulance. Okay, this has happened before. This has happened?
Yeah, I mean that's
You're looking to each other. Has it happened before?
yeah. That's
Okay. All right.
yeah. That's all the transfers, the volume
Okay.
of transfers
Has it
that they've
happened
shown.
that you're waiting an hour?
I think you can give details on this.
Do you guys have any information that you submitted? Is anything in the the inches worth of documents that you submitted that shows that you've been unable to commit to complete these healthcare services because